Hello, everyone. Welcome to today's PermanenteDocs Chat. I'm your host, as always, Alex McDonald. I practice family and sports medicine here in Fontana, California, as part of the Southern California Permanente Medical Group. Today, we're sort of reflecting on last week's National Residency Matching Program. It was the 72nd National Match Day, and we're looking ahead at the future of graduate medical education. And I'm joined by Dr. John Andrews, the VP of GME Innovations at the American Medical Association. So, Dr. Andrews, welcome and thank you so much for joining us.
Thanks, Alex. It's nice to be with you today.
So those of you joining live, please put your questions in the Q&A box. Get them in early. These chats are short and pretty high yield, so make sure you get those questions in, and we're going to jump right in. So Dr. Andrews, just tell us a little bit more about who you are and what you do.
Well, I'm a general pediatrician. I've spent my career working in medical education. I've been a pediatric residency program director, and before moving to the AMA, I was the Associate Dean for Graduate Medical Education at the University of Minnesota and the DIO there. And I've now been at the AMA for about 6 years as the VP for GME Innovations. And my primary responsibility in that role is to oversee our Reimagining Residency Initiative, which was a set of grants that the board of the AMA made to collaborative projects to innovate in graduate medical education. We're in the middle of that right now.
Wonderful. That's great. Yeah, there's lots of, as I mentioned, 72 years of NRMP matching, and then residency in and of itself is, again, similar to medicine in general, this sort of patchwork of different pieces, which, may or may not be serving us at this point. So I'm glad to hear the AMA is doing some work here. Well, again, last week was match day. We saw record-breaking numbers of medical student graduates looking for residency positions. I think there were about 44,000 medical students who matched into almost 6,400 residency programs. Any other kind of stats or information kind of jump out from last week's match you think is important to talk about or to highlight?
Yeah, it was another successful year. The match rate for USMD grads was similar to what it's always been, about 93%. And the match rate for osteopathic graduates was at an all-time high. Back when I trained, osteopathic graduates matched at a rate of about 65%. Now they match virtually the same rate as USMD grads, which is nice to see. The match rate for other applicant categories like non-US IMGs was similar to what it's been in the past. And as you noted, there were a record number of positions offered in the match, and most of those filled. So it was another successul year.
Yep, absolutely. I completely agree. I know it's always very, very anxiety provoking, but also just such a celebratory feeling. The Kaiser Permanente School of Medicine, where I'm one of the faculty there, matched their first graduating class. They all matched. They're all very excited. It was just, the energy was just palpable in that room. And, there's so much time and energy that goes towards, medical school and throughout medical school. And so just being in that room it's a special environment that you really can't duplicate. And every year it's just very, very exciting. So
it's an item of curiosity beyond the medical establishment too. I mean, that there are 40,000 people who learn where they're going to work for the next 3 to 7 years on a single day.
Yeah.
It's pretty remarkable. So it's no surprise that there's a lot of excitement and energy around it.
Yep. No question. Well, let's switch gears a little bit just to kind of some of the residency innovations that you've been working on at the AMA, and just sort of in general. What are some themes or some ideas that are kind of coming forwards to help residency programs innovate to not only attract top level applicants, but also build the training that we need to teach medical students for today, but also meet the future needs of their communities?
Well, there's a lot going on, and I'll just highlight a couple of areas that I think are of particular interest. There's been a lot of recent interest in the transition from medical school to residency and how to make that a smoother transition for those involved. Historically, there hasn't been a lot of sharing of information across the gap from medical school to residency that could better inform training in graduate medical education. And there are a lot of reasons for that. But we're seeing a lot of innovative work to establish coaching programs, for example, that allow coaches at the GME level to meet with students and perhaps with coaches that they had at the UME level and better understand their path to this point and how they might further develop in residency. I think that's really exciting. We've got projects that are looking, to your interest, at ways that graduate medical education can better serve the needs of communities.
Right.
Most graduates of residency programs are technically skilled, but may not be well prepared to meet needs in certain geographic or specialty areas.
Mm-hmm.
And so we're seeing some work on behalf of some of our residency programs to even partner with medical schools to ensure that they're recruiting the right people, people
Mm.
who are interested in serving the needs of specific communities,
Yeah.
and then providing training in environments during medical school and particularly during graduate medical education that prepares them to deliver care and address the social influences on health that are so important to better healthcare for whole communities.
Yeah, no, I think that's a really important point. I mean, one thing just from my own vantage point as a primary care physician, we're facing a huge shortfall. We don't have enough primary care as it is, and I think by 2034, it's estimated we're going to have a shortage of about 48,000 primary care physicians. And so, how can we help? How can we help? We have the workforce we need to really kind of not just treat patients because we obviously need our subspecialists, but can we get enough physicians to prevent illness, really to help save not only pain and suffering but also just the ballooning economic costs of healthcare in this nation.
And I think that becomes a complicated issue to dissect. I think it's important to recognize that the capacity to train physicians to meet those needs does exist,
Mm-hmm.
but that we live in a medical education system that really prioritizes individual choice over collective addressing of workforce needs. And
Sure.
so if you look at the match, as successful as it was, the large number of unfilled positions in the match were in the primary care disciplines.
Mm-hmm.
They were in family medicine, they were in pediatrics, they were in
Yep.
internal medicine. And that suggests that the interest among the applicant pool in pursuing those residencies is less than what it should be to actually meet community needs.
Right.
And I think that we have to carefully consider what the incentives are to enter careers in primary care.
Mm-hmm.
One of those incentives is to find people who are from those communities who want to return to serve there.
Mm-hmm.
And then another that's obvious is to address inequities in salary scale for those sorts of things so that careers in primary care are at least economically more attractive and more balanced with the choices that people might make in other disciplines.
Yeah, no, that certainly makes sense. And obviously we want smart, the best and the brightest going into medicine, and we want them to practice however they feel their skill set best serves. But again, it's that mismatch between what the communities need versus what our medical schools are producing, or the different types of experiences our medical students are having. And there's clearly no easy answer. I think the other piece I want to touch on also that you alluded to is, getting physicians to those communities most in need, the underserved communities, the rural communities. And we know, at least here in California, there's been a lot of energy in the last decade, building more medical schools and graduating more physicians, which is great. However, medical schools don't often lead to physicians staying in that area. We know that residency programs in those underserved communities, I think I want to say the statistic is around 70% of physicians who finish a residency in that area end up staying in that area. And I'm a perfect example of that. I did residency here, and I'm from Vermont, but I stayed here after residency because, again, my kids were in school. I bought a house. Like, that's kind of where you build your life. And so being strategic about where our GME programs are located and what communities they serve. Tell us your thoughts there, or any work that AMA is doing there.
Alex, you're absolutely right. Residency is a strong predictor of future practice location. Some of the challenge in meeting the needs of those communities relates to the way that graduate medical education is funded. The federal support of graduate medical education flows largely to hospitals and supports inpatient training, which, as we would acknowledge, leads to the development of technical skill, but doesn't necessarily expose you to the environments and to the tools that you'll need to provide effective care in a community. Mm-hmm. And so we have some of our programs on our innovation projects, for example, that are working to try to provide as much of that training as possible in the communities where they hope that these people will go on to practice. Mm-hmm. And then the practice environment in those communities becomes less threatening because you understand the resources that are necessary to effectively deliver care. If you've been inside, I'll speak loosely here, but if you've been inside the ivory tower for all of your training, mm-hmm. honestly, the idea of going into a community where you don't understand those resources can be threatening. And for people who've spent a large portion of their time training in those communities, they have a higher level of comfort and investment in those communities to stay. And so as a family physician, you certainly
Yeah.
understand that.
Absolutely. Well, it's interesting you say that, because I remember this very clearly when I was doing my internship at a very prestigious academic institution, which shall remain unnamed. One of my mentors was like, "Well, so what do you want to do after residency?" And I was like, "Well, I really like this and that, and I want to teach, and I kind of really like the academic setting." And he's like, "Well, but you never experienced anything other than the academic setting."
Right.
And I was kind of like, you're right. You mean there's other settings besides the, like, again, because medical school, residency, it's all within that ivory tower, if you will. And so getting residents and medical students exposed into those community settings as early as possible, I think is really important to help them just get a better lay of the land, to know kind of what they want to do.
And we talked about the financing. That's one element of this. There are people in those communities, and again, you would understand this, who are very interested in training residents and medical students,
Mm-hmm.
perhaps to take over for them when they retire from their practices. But their bandwidth to do that is pretty limited. And
Right.
so there are other economic issues that are important to creating training environments that effectively meet the needs of the learners so that they are able to learn the things they need to do to serve those communities.
Yeah, no, that's absolutely right. That's actually a great segue into another question I had. Can you talk about some of the advantages of serving as a faculty member within a residency program, or even as a preceptor in the community, for maybe mid-career physicians who are feeling a little stretched or a little burnt out? I can speak for myself. I get so much energy every July when our new interns start. I get like revitalized and refreshed by this influx of kind of youthful exuberance. And I think our mid-career physicians, and maybe some of our physicians who are feeling a little crispy on the edges, it feels like more work to train a medical student or resident, but there might be some hidden benefits in the long run. So tell me your thoughts there.
Well, you talked about the exuberance, and that certainly is energizing. And I continue to teach. In fact, I just came from my clinic this morning. I teach in a primary care clinic at Lurie Children's Hospital here in Chicago. The curiosity of the learners with whom I interact is just re-energizes me about everything I'm doing. They're asking questions that, when I know the answer, makes me feel confident about what I'm doing. And when I don't know the answer, makes me feel curious about why I don't know the answer and where I might go to find that. So it keeps me engaged and interested in what I'm doing. And as you said, I sort of feed off of their energy for the excitement that they have about the careers that they're developing. It's fun. I think it's fun.
I completely agree with you. My favorite response when a medical student asks me a question is, I don't know. Why don't you look that up and tell me tomorrow? So it's a great way to kind of help teach ourselves at the same time. Awesome. We have a question here in the chat, actually, and it kind of alludes to those, the 6% or so who didn't match into residency programs last week. And what offers of support, or what tools do we have for those medical students who didn't match, unfortunately?
Yeah, that's a complicated issue, because the reasons that individuals fail to match are very individual. You've been through this, and so you understand that in some cases it's people who have records in medical school that wouldn't support matching to the disciplines that they applied to.
Sure.
Perhaps they've failed elements of their USMLE steps, or they've had other academic challenges in medical school that make them less desirable candidates for residency. In some cases, people are very focused in their search in terms of specialty and geography, and that leads them into a narrow funnel where we know that a certain number of people aren't going to match. I think that for the unmatched applicant, it requires a period of self-reflection to understand why you didn't match, and then where there are remediable elements of that portfolio to address those, either through further training and research, occasionally taking a year off and engaging with a faculty member in a way that demonstrates to someone your aptitude can help with that. Sometimes it's making use of personal connections and making contact with programs or program directors who might take an interest in you because of your strong interest in a geographic area or a type of practice. And in some cases, it might involve changing your mind about the specialty you're pursuing. Everybody doesn't get to be an orthopedic surgeon. And as I mentioned earlier, there are many unfilled positions in other disciplines that create capacity for training people who would otherwise go unmatched.
Yeah, I have some colleagues actually who didn't match their first year and they were absolutely devastated, but through, self-reflection, determination, reevaluating what was important to them, they ended up matching and have fantastic careers. And one of my friends, again, who's a mid-career physician, posts every match day his story and to help kind of give some hope, I guess, for those who didn't match. And I always tell people, look, if you succeed or fail, it's your response to that is more important than anything else.
And Alex, that's really important because I think for a lot of people who fail to match, they feel like it's the end of the line, or at least there's a moment where it feels like that. And the best encouragement we can provide is to help them understand that it's not, and there are things they can do to positively address the situation.
Yeah, I agree. We have another question here in the chat. I'm gonna paraphrase it and then pair it actually with another question that I already had. And so they're talking about residency programs here within Kaiser Permanente. We're obviously a value-based integrated healthcare system. So our financial incentives are sort of very different than some outside the KP world, so to speak. But also really thinking about value-based care. And how are residency programs and how is the AMA working to kind of prepare residency programs and prepare residents to really function in a very different landscape than we probably have had, honestly, for the last several decades, moving more towards value-based care?
That's a big area of development. We touched on this earlier. Residency for a long time in this country has been a fruitful environment for developing the technical skill to deliver care. But what we've heard from health systems now for many years is that really takes them a long time to take a well-trained residency graduate and upskill them to deliver effective care within their system. And this is exactly what you're alluding to, like to understand the team-based model, the resources necessary to deliver the care, frankly, using the specific EHR that a system may employ. It just takes time. And those sensitivities are now moving down into the residency training environment. I think there's heightened sensitivity to the fact that when you're training, you need to be exposed to those things and develop some skills in those arenas, as well as your suturing technique and your ability to document a history and physical. So that context for the care that you'll provide is becoming an increasingly important part of residency training. And I think a lot of programs are leaning in that direction.
Yeah, no, that makes perfect sense. Can you tell us about now we have new tools in healthcare. The electronic health record is something that didn't exist when I was in medical school and I had to sort of adapt to in residency. But we also now we're at this verge of AI and iterative AI essentially, and we have these tools that can basically record a history and physical for us, and we don't have to do that. So where is that balance between making sure our residents get those tools and skills that they can do it when the computer goes down or the AI stops functioning, but also balancing that with sort of efficiency and appropriate documentation also?
We had that very situation here at Lurie Children's last month. I think it's been well publicized, but there was a cyber attack. And all of the electronic systems went down, including the EHR and the internet. And they were down for several weeks. And so we were taking care of patients using paper records. And it was pretty amusing to interact with the residents who would bring me these pieces of paper and say, "You used to do it this way, right?" And that was true. I think that I'm a bit of a Luddite in that I have some concerns that the accelerated use of AI could lead us to technical solutions that hardwire bad processes into the care that we're delivering. In other words, I think AI is a really effective way to render an effective human process more efficient. But if you haven't nailed your human process, AI is not going to make it better. And so residents still have to have the opportunity to engage in the things that contribute to the development of that record about a patient and to understand where AI can help and where it can't. And I think that's going to be a real challenge. I mean, if we reach a point where the delivery of care depends so heavily on those tools that you don't understand the basis for the information that they're using, I think we're going to have a real problem. So we're going to have to think carefully about that going forward. And I don't think the answers are evident at this point.
Yeah, no, I would completely agree with you. And just from my own experience, utilizing some of these AI tools and like just to put my phone down in the exam room and literally connect with the patient in front of me, like brings so much of that joy back to medicine about how I practice. But then if it stops working, I still have to document, right? Or I still have to
Right.
know how to
Right.
use those backups because we become so reliant on technology. So I think that's something we're definitely going to have to grapple with. And we've
Now,
had
we
some
need the
conversations with
technology
my
to work for
mentor.
us, not for us to work to the technology. That's the key.
Exactly. I like can you say that again? How AI will help a human process? I love what you just said there.
Well, I just think that AI can render effective human processes more efficient.
Perfect.
But if you don't have effective human processes, AI is not going to fix them.
Perfect. I love that. All right. Good thing this is being recorded because I want to go back to that phrase. I love it. Another question here in the chat. So exposure to medical students and residents in the community setting is often on a voluntary basis and depends on the bandwidth of physicians and clinicians who may really not have the infrastructure of those larger academic institutions, which can lead to widely varying quality and experiences. Do you have any thoughts about how we can address this, or how the AMA is working to address this?
Well, it's a real problem. I wish that the funding model for GME were different.
Yes.
That the funding flowed more to the trainee than to the institution where they train. In other words, if the funding supported the training that the trainee needed in whatever context that took place,
Mm-hmm.
that would be more effective from a training standpoint. Now, obviously, hospitals are going to have some important things to say about that.
Right.
I think we have for too long relied upon volunteerism and the good nature of people in the community to train our residents and medical students. And the environment around them has changed to the point where that's no
Yep.
longer a tenable
Yep.
situation.
Agreed.
And so the economics are going to have to change. There's going to have to be some reimbursement or at least some consideration of the effort that people in the community make to participate in our training programs so that they remain skilled at what they do and enthusiastic about engaging with trainees over that.
Yeah, we'll have to do a whole nother chat on the
Yeah.
policy of GME funding because that is a giant ball of yarn that's so tangled up, it's
I
mind-boggling. But we'll
agree.
talk about that later. Okay, this has been phenomenal. We like to keep these short and high yield. So my last question here: what makes you most proud to be a physician?
Uh, the thing that makes me most proud to be a physician is I'm a pediatrician, and I love working with children. I love their innocence and their resilience. And when I go into a room and I can have a conversation with a child that goes well because I know how to interact with them, that makes me feel proud. Like if I
Yeah.
can put a child at ease and make them feel a little better about the health care that they're receiving, that makes me feel really proud.
Amazing. Perfect. Well, thank you so much for joining us today. Thank you for sharing your insights and all your work that you are doing, and excited to keep on the adventure with you.
Yeah, thank you, Alex. This was fun.